Welcome to Supporting a Healthier Missouri, a three-part discussion about Medicaid expansion in Missouri. Thank you so much for joining us for this critical conversation leading up to the August 4th primary election, when Missouri citizens will have the opportunity to vote on Amendment 2 Medicaid expansion. Today's conversation is the second in a three-part series, and today we'll focus on the implications for rural communities who face unique healthcare challenges. I'd like to take a moment to thank our sponsors, the series sponsors, the Center for Health Economics and Policy, the Clark Fox Policy Institute, the Integrated Health Network, the Brown School. And now please join me in welcoming Mary McKay, the Nidor Family and Centene Corporation Dean of the Brown School at Washington University in St. Louis. Mary?
Hello, everyone. Thank you, Atia, and thank you to all of our panelists today. I have the privilege of welcoming you to this important conversation. It is the second in a multi-part series where we try to highlight what I think is incredibly an important opportunity that Medicaid expansion allows us to consider, particularly for populations that may have had challenged with their own health, accessing health care, and really trying to advance what we call in the Brown School health equity, which is to really go at directly the disproportionate burdens that members of our community, particularly our Black and Brown neighbors across our state, really experience as a result of this public health challenge, but many others in the health arena. So it's my privilege to be among colleagues that are scientists I know, the best clinicians that I'm aware of, the best kind of consultants to policymakers. And what I really feel so strongly about this particular series is the things that we're going to talk about are based on facts, based on science, based on best practices and opportunities. And I think that's an incredibly important role that our university plays. But I also think that I'm grateful to Atia Yu, Cynthia Williams, who is really one of the chief architects of this series, because you're able to translate really existing knowledge and research into actionable items for our communities, for our citizens to move upon. And so I'm grateful also for the partnership with the Dean of the School of Medicine. David, you have been fearless in this space of talking across the state the importance of Medicaid expansion and the opportunities that it provides. And so I'm grateful for the partnership of campuses and our schools. So David, a few words from you as we get to our panelists.
Thanks, Mary, and thanks from me to the Clark Fox Policy Institute and the Brown School for bringing us together to talk about this important topic. Medicaid expansion is really important for our rural communities, and that's what we're going to hear about today. I want to just say that the university, together also with the School of Medicine, is deeply committed to addressing disparities in our community. And we know that one of the major disparities is in healthcare. And we want to work towards meaningful and lasting change. A central strategy in this work is supporting the passage of Medicaid expansion, which will appear as a state constitutional amendment, Amendment 2, on the August 4th statewide ballot here in Missouri. There is tremendous energy and enthusiasm and excitement here on the medical campus. We have many groups working towards getting all of our members of our community to vote. Several of our student groups, including Lou Health, are helping people to get absentee ballots requested and notarized, and are volunteering to help at the polls on election day. It's been pretty overwhelming to see how our faculty and our staff and all of our students are supporting the initiative. It is really important for us to all be working together on this effort, and in particular to dispel the myths that about who would benefit from Medicaid expansion. Since I came back to Missouri in 2000, at the end of 2015, I have been trying to think of how we lead our community in taking care of in taking advantage of the opportunity that is afforded by the Medicaid expansion paradigm, which will, because it will bring coverage to an additional 230,000 low-income working Missourians. Many of these individuals live in rural Missouri. They are working in jobs that don't provide health insurance, and they earn too little to afford health insurance on their own. Because their incomes are at or below the poverty line, they do not qualify for federal tax benefits to purchase private insurance. It is due to the fact that they are working and trying to earn a living to benefit themselves and their families. They cannot qualify for health care benefits under federal or Missouri law. And the sad truth is, when Missourians are uninsured, they are less likely to seek care when they are sick. If many of you are participating in the Zoom today, chances are you've never had to choose between paying the rent and consulting a doctor about a suspicious lump or a nagging pain that refuses to go away. Too many of these individuals wait until their health deteriorates and they are in a medical crisis before they seek care because of the fact that they're worried that they don't have insurance to cover the cost of the consultation. And this problem then becomes the start of multiple problems that can turn a family into a major crisis. Here in the St. Louis region, citizens are fortunate to have a number of excellent hospitals and clinics to choose from when we need medical care. Some of our citizens in rural Missouri are not so fortunate. There's no hospital or urgent care nearby for them to get the care that they desperately need. 10 rural hospitals in Missouri have shut their doors since 2014, forcing people to drive longer distances to reach a hospital when suffering from a heart attack or a stroke or another medical emergency. An additional 26 Missouri hospitals are considered vulnerable to closure. Each one of us can make an impact for our rural neighbors. Passing Medicaid expansion will provide the support that our rural hospitals and clinics have the need to stay open and provide critical care. And we know from the data of other states which have taken care of this who have taken advantage of this opportunity, that the results are improved access to care, improved outcomes from care, improved financial security, and improvement in the state economy for further investment in the population. So I want to thank you for inviting me to join for this important discussion, and all of you for being interested in this incredibly important moment. Thank you. I'll turn it back to Tia now.
Thank you, Dean Perlmutter. Those were exquisite remarks about the state of affairs in which we face, in which we have the opportunity. So thank you all again for joining us. It's my privilege to turn the program over to my co-moderator, Cynthia Williams.
Thank you. My name is Cynthia Williams. I am the Assistant Dean for Community Partnerships at the Brown School. Good afternoon and thank you, Dean Mary and David, and welcome to all of our panelists and attendees. I also want to acknowledge my colleagues, Atia Thurman and Janet Gillow and Gary Parker, who is the executive producer, but who is not with us today, but is with us in spirit. So we are sending also best wishes to Bethany Johnson-Jawad. She was also scheduled to be co-moderator today, but she took ill this afternoon. So we just want to send best wishes to her. Now, turning to our esteemed panelists, I'm going to ask each of you to please introduce yourself, your organizational affiliation, current roles or projects, And so I'll start with you, Tim, please.
Yeah, good afternoon. My name is Tim McBride, and I'm the Bernard Becker Professor in the Brown School at Washington University, and I'm also co-director of the Center for Health Economics and Policy, one of the co-sponsors for this event. Thank you.
Ryan, would you mind? You're on mute. You're on mute, Ryan.
Thank you. Sorry. Ryan Barker, I'm the Vice President of Strategic Initiatives at the Missouri Foundation for Health. Just moved into a new role in January after 17 years in the policy shop. I oversee our Advocacy, Leadership, and Collaboration Initiative, our Civic Engagement Initiative, Medicaid Expansion Initiative, and the Foundation's Opportunity Fund. Happy to be here today.
Thank you. Paul.
My name is Paul Taylor. I'm the CEO of Ozarks Community Hospital. We are a safety net provider. We have one hospital in rural Arkansas. It's a critical access hospital. We have 13 rural healthcare clinics spread over 3 states, but 12 of which are in the state of Missouri. And I tease that I'm the token rural provider on the panel, and I'm largely here because I've had the unfortunate experience. We were a health system with 2 hospitals, one in Missouri and one in Arkansas, but the Missouri hospital closed, and my position is would not have closed had we not expanded. Had we expanded Medicaid back about 8 years ago when we could have and should have.
Thank you. And last but not least, Will, please.
I'm Will Ross. I'm a professor of medicine and the Division of Nephrology at Washington University School of Medicine. I'm also Associate Dean for Diversity and the Principal Officer for Community Partnerships at the School of Medicine. But I have 2 hats that I'm going to wear here in this forum that are equally important. I serve as the chairman of the board for the City of St. Louis Department of Health, and I'm a member of the Regional Health Commission, one of the founding members of the Regional Health Commission, which spawned the Integrated Health Network. And so I'll try to bring all those perspectives into this discussion.
Thank you so much. Going right into our questions, I'm going to direct this question first to Ryan and then to Tim. Why, so we can level set for the audience, why is Medicaid an important mechanism to ensure that all Missourians can achieve health and well-being?
Yeah, thank you, Cynthia. Really, the number one thing is the research is very clear that health outcomes for patients are extremely better when they have health insurance versus when they're uninsured. We know that the uninsured delay getting care, that they often wait until they're really sick, they get a diagnosis that is later in the disease state, and ultimately that results in poorer health outcomes. There has been tons of research on the Medicaid program, and health outcomes for patients in Medicaid are much closer to the same health outcomes that we see with private insurance patients. In terms of rural Missouri, it's just we need to maintain access points in rural Missouri. The foundation has seen, we have heard for 18 years from our rural communities, transportation is the #1 barrier to healthcare. The more access points we lose in rural Missouri, the harder it is for our rural counterparts, communities to receive access to care. I'll end with one thing. Not only are these rural hospitals and rural clinics access points for patients, in many of these towns, those hospitals are the largest employer. So we're talking not only is this a healthcare access issue, this is an economic issue that is important to keeping these rural economies thriving.
You know, the only thing I'll add to Ryan's excellent summary of this is, you know, if Missouri expands Medicaid, we will be the 39th state to expand Medicaid. And so we are the show me state. So we would like to wait and see what others have done. And so there are some 400 or plus studies now that have looked at Medicaid expansion. And I'll put something in the link in a minute of a really excellent summary of this from the Kaiser Family Foundation that's looked at a lot of those studies that Ryan's mentioned. And there's pretty much incontrovertible evidence now that shows that Medicaid expansion leads to greater access to primary care, preventive care, specialist care for low-income individuals. And you can look at that evidence if you want. And so it leads to greater access for rural and urban individuals. As Ryan mentions, we've known this for decades now, that pretty much the Medicaid individuals have access that's pretty much equal to people with private insurance. And also, I think really importantly, one of the first things that happens is it reduces financial stress for individuals. People with low incomes face very significant financial stress, out-of-pocket costs, and medical debt, and evictions. There's a really good study by one of my friends, Heidi Allen, that came out recently. It shows that Medicaid expansions leading to less housing evictions and financial stress and bankruptcies. So it reduces the difficulty for paying medical bills. Here in Missouri, 53% of low-income uninsured individuals report problems paying their medical bills. So, you know, the people who are uninsured right now are facing that kind of stress. And the dean, I won't go over the numbers the dean laid out, but they were quite clear about what's the stress that we're facing in rural Missouri. And I'm sure Paul will lay it out pretty clearly. Paul and I will sort of talk about that more later, about the stress that rural areas are facing. So, but it's clear that the transition from non-expansion to expansion, the evidence is pretty clear on this. You're on mute, Cynthia, sorry.
In the United States, approximately 60 million people call rural America home. And in Missouri, over 1.5 million, or 30% of our residents, live in rural America, rural Missouri. So the question is, can you help us, Paul, define what are the characteristics of rural Missouri?
Yeah, it's always interesting to me that in my business, the healthcare business, the operative definition is the Medicare definition. And Medicare definition of rural is in the negative, which tells you all you need to know about the primary focus of most policymakers. So they define rural as being everything which is not urban. Mm-hmm. So to figure out what is rural, you have to go look and just find out what is urban. And urban is defined as being a population center of 50,000 people or more. But they look at the maps and they follow population density. And so you get some pretty odd results and gerrymandered maps just based on population density. And it can cause some gray areas that are pretty interesting. I mean, in my neck of the woods in the southwestern part of Missouri, Jasper and Newton County, because Joplin straddles both counties. Both of those counties count as being urban. But if you look at the counties and you travel those counties and you get outside of Joplin, which is right at 50,000 people, most of Jasper and Newton County is rural. And you wind up with a town situation. Webb City, Missouri, where I live, is smaller than Carthage, Missouri. But Webb City, Missouri is nearer to Joplin. So Webb City is considered urban and Carthage is considered rural. My health system has a clinic in both Webb City and Carthage. And so we end up being a rural healthcare clinic in Carthage, which is larger than Webb City, and we're an urban clinic in Webb City. And the characteristics of rural that should matter to the people that are voting about Medicaid expansion are there are some pretty stark disparities. There are 101 rural counties in Missouri and 14 urban counties. And as you indicated, I mean, we've got around 4 million people urban and under 2 million that are rural. There's a huge income disparity. The per capita urban income at $43,000 in Missouri, $33,000 for rural. Higher percentage of the elderly live in rural, 17.7% in rural and 14.5% urban. A higher percentage of the uninsured in rural, 14% uninsured in rural, 10% urban. But let me pause and talk about that number because it also includes Jasper and Newton County as urban. And in fact, Jasper and Newton County are two of the highest uninsured rates for counties in the state, and yet they fall over on the urban side and arguably more rural in those two counties. There's a lower percentage of college educated in rural. 17% of rural citizens Missourians have a college education, and 33% of urban Missourians do. And for this discussion, one of the principal differences, and it's a huge disparity, access to primary care. Primary care provider ratios in Missouri are 55 for every 100,000 in rural, and 139 primary care providers for every 100,000 in urban. And so that's a stark number, and that is the point. There's not enough access to primary care in rural America, and if you can't get transportation, and the only way you can get to a primary care provider is by accessing one in an urban area, then it means you're just simply not going to get access to primary care. And so what's the result of that? Well, higher percentage of rural women are unhealthy, higher percentage of rural children are obese, rural Missourians are more likely to die from each of the 10 leading causes of death, including suicide, than urban Missourians. So it's a healthcare disparity.
Yeah, if I could I just jump in on that, Cynthia, too, just to put a punctuation mark on that. I totally agree with everything Paul said, but if you sort of add up everything he said, sort of lower incomes, higher poverty rates, lower educational attainment, you sort of put that together, the job opportunities are worse in rural America, which means less access to health insurance. So that's part of what we're talking about here with Medicaid expansion. So Paul also mentioned higher uninsurance rates. So that's why Medicaid expansion paradoxically matters more in rural Missouri than it matters in urban areas. The estimates that we produce for our Center for Health Economics and Policy actually shows that a higher proportion of rural people will get covered under the expansion than urban. That might really surprise people. And it's mostly being driven by suburban areas, which have pretty low uninsurance rates, like suburban Kansas City, St. Louis, and so on. And again, as Paul mentioned, higher aged populations in rural areas, and then higher rates of chronic disease in rural areas. So, and then another point, and I'm sure will jump in on this as well, is one of the things that I've done rural work most of my career. I find that there's a lot of similarities between rural America and central cities. Everything we've mentioned about poverty, low incomes, lack of access to good jobs, high chronic disease characterizes both rural areas and central cities. So those problems and lack of access to primary care are problems in both rural Missouri as well as central cities. And so really, they're not problems where I live in suburban Missouri, St. Louis. And so the struggles that, rural Missouri is facing and that Medicaid expansion can help is going to help rural Missouri and parts of, central cities across the state. So, again, Medicaid expansion is going to help rural Missouri a lot.
And Tim, if I could, this is Paul. If I could jump back in to hammer home one point that Tim was making, which is about diversity in rural America and in rural Missouri. A lot of people think, well, rural Missouri is mostly white, and it, there are a lot of white folks in rural Missouri, but it's not just a lot of white people. Anecdotally, I can tell you we have a clinic in Knoll, Missouri, which is in McDonald County, very extreme southwestern Missouri. And in Knoll, Missouri, where there happens to be a chicken processing plant, the local high school put a map of all the countries in the world up in the high school hallway. And every time they got a student from a country that they hadn't seen before, they'd put a push pin on the map in that nation, in that foreign country. And the last time I checked, that map had 57 push pins in it. So there were high school students in the Knoll High School from 55 different foreign countries in a very small, remote, rural corner of Missouri. So there is a surprising amount of diversity these days in the rural population.
Well, that's just a great intro to what I was going to say, Paul. First, before I make that comment, I just put up on the chat a reference kind of alluding to what Tim was saying about what happened in small towns between 2008 and 2016 when the uninsured rate fell from 35% to 16% with Medicaid expansion. That's pretty remarkable compared to only a 5% drop in non-expansion states. And so it clearly is going to have a benefit. But I just want to weigh in on what Paul just said, because a recent report, this was actually a task force, a congressional task force, which just convened last month, looked at that precise area. And although rural America is about 80% white now, that has indeed changed. I know the prediction is that within 10 years, rural America will actually have the diversity of what our population looked like in 1990. Now that's going back a little bit, but still, we were quite diverse in 1990. Rural America is becoming that diverse. And that begs us to really look at what we mean by rural. I think we had this conversation to start. We sometimes are making these statements that imply that there's a homogeneous population in rural communities and a homogeneous population in urban communities. But I think it's better to look at a way of stratifying rural and urban communities based on rural being the overall umbrella, but then looking at those communities that are resourced or under-resourced. And it is those under-resourced communities in rural America and urban Americas that actually are characterized by these remarkable disparities we're going to talk about. In those under-resourced communities, whether you're rural or urban, the life expectancy, actually in 2009, the life expectancy for low-income Black and rural, low-income white and low-income Black rural residents was that which was achieved by urban whites 40 years earlier. So it took 40 years for the life expectancy in rural America for those under-resourced individuals to reach a life expectancy that whites had achieved 40 years earlier. And so I think as we have this conversation going forward, we really want to make sure that we, again, focus on that rural, for the most part, the rural underserved, under-resourced community, which certainly will benefit from Medicaid expansion. We all will, but let's make sure that we don't use this broad brushstroke when we talk about rural communities.
Thank you so much for that. I want to go back to something Paul said and Dean Perlmutter mentioned, and we're talking about the benefits. I want to think about people, and I'm going to change my framing because of what Dr. Ross said and what Paul and what Tim are saying about the diversity of rural communities. I want to say that people who live in rural areas of Missouri, they have a different kind of healthcare experience, maybe somewhat parallel to people living in urban areas of Missouri. And I want to talk about how Medicaid expansion changes that day-to-day experience of healthcare and well-being for people who are living in rural areas of Missouri. How might, or what we can expect, should we pass Medicaid expansion in this state? What are some of the things we can expect, the barriers that are removed, or how does Medicaid expansion facilitate better health outcomes for people living in rural areas?
Well, and this is Paul. I will jump in on that because I live it and have lived it. And let me tell a story, and principally why I'm here today is tell the story of Ozarks Community Health System and what we've experienced in the last 8 to 10 years since it would have been possible to expand Medicaid in Missouri, and we didn't. As you go back to 2012, my hospital in Springfield, we were a heavy Medicaid provider. I had 3 large clinics in the urban Springfield area. I had over 1,000 employees. Just in the Springfield area, in those 3 clinics, I had over 50 providers. We were treating over 22,000 Missouri Medicaid patients in that market. I mean, that was a very high. We were the highest Medicaid primary care provider in those clinics than any other system in the state of Missouri. And along about that point in time, about a decade or so ago, Missouri Medicaid tweaked some things, and so there was a circumstance that happened where there were a number of folks that dropped off the Medicaid rolls at one point in time about 10 years ago. And what I saw in my Missouri hospital was that our census in the emergency room almost doubled when that happened, and so patients began patients recently uninsured because they were dropped off the Medicaid rolls. Instead of going to primary care providers, we're now hitting my ER. The percentage of patients who were uninsured in my ER went from about 30 to 35% to 75%. So our ER in North Springfield, which was largely a rural population that comes in from outside Springfield, but also the poorer part of Springfield, if you will, the older and poorer part of Springfield and North Springfield, hitting my ER. And so we got swamped. We got swamped with uninsured patients. We got swamped suddenly with patients that had lacked access to primary care because they were no longer covered under the Medicaid program. So we got a small little, a study done, if you will, of that impact that could be made, the difference between having Medicaid coverage for that patient population and not having Medicaid coverage. And it frankly overwhelmed my ER to the point that we had to, take some steps to do certain things in the ER and try to getting patients taken immediately from my ER over to see primary care providers. And so now fast forward, that hospital in Springfield struggled economically, financially, and in 2016 closed down. And for my money would not have closed had Medicaid expanded back in 2012, 2013 when it could have. And so now what do I have in Springfield? I'm not a hospital, and no longer do I have these 3 large multi-provider clinics. I've got 1 clinic, and that 1 clinic I've got about a half a dozen providers. I have about 40 to 45 employees. And instead of being one of the largest employers in the city of Springfield, I'm now not even on the radar. And so from a standpoint of being able to provide an extraordinary amount of primary care for Medicaid patients, we lost one of our largest Medicaid primary care providers in that Springfield market. And those patients are largely uninsured and largely unable to access health care. And when they do access health care, they're going into the remaining hospitals in that area. They're hitting those ERs. And when they do hit the ER, they're more acutely ill, which means they're going to cost more money for those hospitals to take care of them. And the outcomes are going to be worse. And so my system is a living, breathing example of what happened in a state that failed to expand Medicaid. Across the border, my hospital in Arkansas, on the other hand, has expanded. I've expanded the clinics that are tied to that hospital. So now that hospital is the anchor for not only a large clinic in Northwest Arkansas, but a dozen other rural health clinics. When we look at our ER census has not only not increased, but since Medicaid expanded in Arkansas, our ER daily census has actually dropped Our percentage of uninsured in the ER is now less than 5%, whereas previously it was the same as it was in Missouri. It was, 30, 35%. And our outcomes are we're keeping people healthy. We're keeping people in primary care clinics in their medical homes, and we're keeping them healthy, and we're keeping them out of the hospital. We are the hospital in Little Gravette, Arkansas, where the hospital is located. We're the largest employer in town, by far the largest payroll. And the little town of Gravette, Arkansas, the population has almost doubled in the 10 years we've been there. And it's a thriving small town in rural Arkansas. And so it's not just about the health of the patients, it's also about the economic health of the community. So the final thing I would say about that is I live in Missouri. I'm a taxpayer in Missouri. And it does bother me that I pay federal taxes, and every year I see some of my tax money going out of Missouri and going to states that did expand Medicaid. I've seen the estimates that we've lost about $500 million a year on the net outflow of Missouri paid tax dollars that are going, out of Missouri and going to states like Arkansas where they did expand Medicaid. So do the math. I mean, we could have expanded Medicaid back in 2012. We've been sitting here for 8 years. It's very frustrating for a guy that sits here and immediately deals with the economic fallout from that. But we've also literally lost billions of dollars, $6 billion or more, just in tax dollars that have flown out of Missouri and gone into other states that have expanded Medicaid. It's frustrating. It's irritating. It's discouraging.
I hear you, Paul. Tim, did you want to add anything to that? Otherwise,
I think the one thing I would just say is that's an amazing and sad and I'm sure it's a frustrating story for Paul, but what I want people to hear about that story is that's a case study that illustrates the 100+ rural hospital closures in the United States that's happened, that the dean mentioned earlier, and the 10 or so plus that have happened in rural Missouri. So what you just heard in that story, if you didn't believe the research, that's a real person telling you what they went through. And so, and you heard why it happened. And so there's been numerous research articles that have laid this out. You can go to the University of North Carolina's website and see all the list of all the hospitals that have closed. And so the story he told is exactly what happened. And I've heard from CEOs before that basically these hospitals run a small negative margin, and then they can maybe make it go, but if they don't have the Medicaid expansion, you can't be running a negative margin year after year after year. Your board's going to say you got to shut down. But if you're in a state that has a Medicaid expansion, that negative margin becomes a positive margin, and then you can stay open. So, Paul's experience of being on a border where you got the positive margin on one side of the border and the negative margin on the other is like the perfect example of case study. And there you go. What else do we need? And it's sad. But, I'm not going to say that every hospital in rural hospital in Missouri is going to turn it around if we expand, but it's going to be a more than $1 billion of federal dollars that's going to come in to the state if we expand, and that's going to be an important infusion of federal dollars to the state, and we can talk about that economic benefit if we want further. So.
I want to say we're talking in very big scale. We're talking in scales of cities and hospitals. I just want to remind, I know everybody on this call realizes that we're talking about humans every single day. We're talking about
exactly.
We're talking about the loss of, we're talking about diminishing the health of our workforce. We're talking about families being able to manage, rising out of poverty, and this affects people every single day of their lives. So we talk about it in great scale, and I actually want to talk about it in a larger scale now, going from the day-to-day life, going from running a hospital. I'd like to scale it up to the whole state and talk to Ryan a little bit and pose a policy question. Ryan, this is what are the policy implications for expanding Medicaid across the state? And what do we see happening in terms of coalitions that are coming together to try to pass this policy?
So yeah, a couple of things related to that question. So statewide, yes, there are real human impacts we expect as a report put out by Tim at WashU last year. We expect about 230,000 Missourians to sign up for Medicaid if the program is expanded. That includes right now, if you are a childless adult in Missouri, it doesn't matter what your income is, you are not eligible for Medicaid. And that includes 60% of the homeless in our state, which is, those are, as you just pointed out, that those are real people and real humans where we could provide such better care and preventative care because a lot of homelessness has to do with mental health and substance use issues. The other thing I want to I will post in the chat a link to our most recent report that we did in collaboration with REMI, and it is an economic report. And as Paul was saying, there is a real economic impact to Medicaid expansion that will impact the entire state. That REMI report talks about how there will be an increase of $2.5 billion in economic output across the state, including $1.6 billion in increase in gross domestic product and $1.1 billion in increase in personal income. That personal income comes from the fact that all these new billions of federal dollars flowing in to the state will create jobs. And the REMI report shows that on average, we'll gain about 16,000 new jobs per year. And the thing to know is that almost 80% of those jobs will be outside of healthcare. So as Medicaid dollars come in, they go towards providers and services and equipment. That money then trickles down through the economy. And this REMI report asked us at the foundation, like, how do you want to define a quality job? And we decided that we really wanted to define that as a living wage job. And 9 out of 10 of these new jobs being created will pay $15 or more per hour. And then specifically in the rural part of Missouri, 64% of these new jobs created will be outside of the St. Louis and Kansas City area. So it's a real economic impact. And as Paul was pointing out, when you have Medicaid expansion, not only can these rural hospitals sort of stabilize their finances, but many of them are able to expand their services. We have a large number of rural hospitals that are seeing patient loads in their catchment area. The average uninsured in the state of Missouri is about 15%, but many of these rural counties have uninsured rates well above the average, anywhere from 15 to 30% uninsured. So this really is a statewide issue, but it has real economic impacts throughout the state and especially in rural Missouri.
Can I highlight some things that Ryan just said? That was outstanding, Ryan. I saw a chat in the chat comment about the typical population will benefit from Medicaid expansion, and they're characterized or stereotyped as being lazy, not working. I think Ryan just answered that question beautifully. That these are hardworking people working 2 or 3 jobs if possible to really support them. A lot of these people who can benefit are women, mothers, their aunts, their sisters, who really aren't able to access perinatal services for routine health care. It's just striking. The ACOG report, American College of Obstetrics and Gynecology report, about 5 years ago showed that almost half of women in rural communities can't access perinatal services within a 30-minute drive from their home. That's just striking. And so that's one of the reasons we see such higher maternal mortality and infant mortality in the state of Missouri, because these women can't access those really basic services. So these are not people at home sitting around watching TV. These are hardworking people. These are people with 2, 3 jobs. These are your mothers, your sisters, your aunts who are trying to access basic services. These are the ones among all of us who will benefit from Medicaid expansion.
And Will, I'm gonna build on that really quickly, because one of the best ways I have found to talk about that that myth or idea that folks are lazy is the current Medicaid system, especially for parent category, is really a disincentive for people to work that have any sort of pre-existing condition or a chronic disease that they're trying to manage. Currently, if you're a parent in Missouri, if you're a single mom with 2 kids, you can't make more than $4,700 per year and be eligible for Medicaid. And so if you have, let's say you have diabetes and you need insulin to be a good mother and take care of your family, and you have to take care of your health, there is no way that you can work even a part-time job and not lose your Medicaid coverage. And so actually Medicaid expansion we see as an incentive to work. So you can actually work and maintain your health benefits and take care of yourself and your family at the same time. But really the current way we have our Medicaid program set up, it's a disincentive for parents to be able to work because they can't keep their health insurance.
And I just have to jump in on this one too. I've been doing research on insurance for over 30 years, and we know from all the research that 80 to 85% of the uninsured are working. And the people who are currently not eligible for Medicaid are single people, single males, single females, and married couples. And the biggest gap, in addition to what Ryan just said, that if you make over $4,700, if you're a custodial parent, there's a gap in Missouri that between that number and the poverty line. That's what this Medicaid expansion is going to fill. And actually, paradoxically, I think this is rather bizarre in many ways. One of the criticisms of Medicaid expansion is it's going to offer coverage to the so-called able-bodied people to get coverage. But in fact, actually, that's the point. As Ryan said, it's an incentive to actually keep your job and get insurance. So most of the people, I know this from all the research I've done, is most of the people that are uninsured right now are working, so they're doing all the right things. They're going out to work. They're just not offered insurance because their employer cannot afford to offer them insurance because they're low income. That's the whole point.
And this is particularly relevant in this time of COVID, as we've seen the unemployment rate skyrocket, and we know which populations have been impacted. And clearly, rural Missouri is taking a heavy hit. And so that opportunity to get gainful employment is lessened right now. And so this is why this is even more of an issue, a timely issue to have Medicaid expansion at the state.
Thank you all so much for your responses. Will, thank you for watching the chat so closely, because you covered a major question that we wanted to answer from the chat. And also, here are common questions that people have asked about expanding Medicaid. So this is open to the panel, but Will, I would like to start with you. The questions are, will Medicaid expansion raise the state's costs due to expanded coverage? Will it place undue burden on the state to implement? And will it incentivize women to get abortions?
This question is for whom?
Starting with you and all of the other panelists.
Well, I want to talk about this issue because I know this has come up before, and that's, I kind of alluded to maternal health care. Yes. About this issue of accessing abortion. Part of the issue is that right now, I kind of talked about this before, that particularly among the underserved, historically underserved groups who are both rural and urban, women have a 33% higher risk of higher maternal morbidity and mortality. Higher rates of low birth weight. These women actually, with expansion of Medicaid, would have greater access to preventive services, greater access to women checks. They're going to be healthier. They're going to be less likely, okay, this is converse to popular opinion, they're going to be less likely to seek abortion because they're going to have all this long-term preventive health care, this interconceptual care that's going to make them healthier. And so that's the myth we have to debunk. that we actually, and that's been seen across the board in states that have expanded also.
And if I could jump in on the fiscal analysis of this and whether it and the budget effects of that that you mentioned, Cynthia. So our center was contracted by MFH to look at this question, what would be the effect of the Medicaid expansion on the so-called general fund for the state. And we were asked the narrow question of what would be the effect on the Mo Health Net or the Medicaid budget. And we looked at the effect initially on the 2020 Medicaid budget and then out years. And the general conclusion, without getting into all the weeds and details, is that it's basically budget neutral, but it saves about $40 million in 2020. If you expand it out, it saves quite a bit of money by 2026, about $1 billion. And I could explain why that's the case. The main sources of savings there are certain populations that we currently cover. Well, first of all, let me say that the federal government pays 90% of the cost of the new expansion population. So that's what's really important for people to understand and that's written into the law. That can't be changed unless Congress changes it and the president signs it. So that those 230,000 adults that Ryan talked about that we estimated would be covered, the federal government would be paying 90% of that. The state would pay 10% of the cost of that. People get worried about that 10%, but there are savings that the state would have that we estimated would come from people that there are certain groups that permanently and totally disabled, the spend down population, a few groups. I'll post a link to our study so you can see it and understand it, that people that now come through the Medicaid program after expansion, they would come through and the state would, instead of having to spend 35% on those groups, they would spend 10%, and it would be about a $40 million savings and then grow to about $1 billion. So we think this actually would save the state money. And just so that may surprise people, but we did a lot of analysis of this, and this has been found in almost literally every other state that's expanded Medicaid. And I'll tell you that every other state that's expanded Medicaid has not reversed that decision. So that's important to know. And so, let me just say that again, no states reversed their decision. And when we did our analysis, we looked at all the other states' experience. Again, if we do this, when you vote on this on August 4th, and this is the last day to vote by absentee, by the way, we could look at the experience of other states, and our center did that. So we had a lot of evidence and research to look at, and so we feel quite confident in our analysis, and I'll post a link to it in a minute. I hope that answers your question, Cynthia.
Thank you, Tim.
Thank you, Tim.
Paul, did you want to say something more? Because I have one more question, and then, so I am curious, Tim, and anyone can answer this question. How might expanding Medicaid also open up the door for innovation within our healthcare system?
This is an interesting question. The state is currently thinking about transforming Medicaid, and our center had a meeting on this just yesterday. And our Medicaid program is certainly needs a lot of transformation. I think everybody agrees with that question or that point. Although I frankly think that there's a lot of things that are very good about our Medicaid program. We have patient-centered medical homes. We were one of the first states that expanded our Medicaid program to 300% of the poverty line for children, and so on. So I don't think we should beat up on ourselves completely about our Medicaid program, but I think that a Medicaid expansion may create some interesting opportunities for us to innovate. It would bring in some dollars to the Medicaid program. I think we have some good leadership in the Medicaid program right now. Director Richardson is a very smart guy who's thinking outside the box. Kirk Matthews in the transformation office is thinking creatively as well. I really like his idea of getting the enrollment application from 60 pages down to 16. I think that's a great idea. Really applaud them for that. And they're working hard on things to improve the IT. When I was chair of the oversight committee, we complained a lot about problems with the IT program. So, you know, maybe some of these dollars that flow into our through expansion could help to improve our IT. I mean, by that information technology, sorry to use acronyms. And, you know, if there's some dollars that get infused into rural health and urban systems, we could maybe improve some of our innovative ways we pay. You know, a lot of what we talked about yesterday was paying for social determinants of health to get pick up on some of the themes that we talked about earlier about diversity. We really need, that's the way that we're moving in a lot of healthcare these days. So those are some things I'll throw out. Others can jump in.
Well, this is Paul.
Yeah, Paul.
Well, I'll just say, and following up something Tim mentioned, but there's a very innovative and very successful program that Medicaid is doing right now, which is the primary care medical home program that our system may, I think, have one of the biggest patient populations enrolled. We have over 2,000 Medicaid patients enrolled in that program now, and it's a tremendous program. I'd love to see it franchised in all 50 states, but immediately what would happen in Missouri is if we expand Medicaid, you simply enroll more patients, those uninsured patients that now are not covered and being seen by primary care. And that the program is basically designed, it's an outreach program where not only do you see the patient when they come into the clinic, but there's a lot of caseworkers that are reaching out to the patients and making certain that they're taking their medications, that they're eating healthy. Then if they need, we provide a lot of transportation for patients to get them into their appointments. And so it's a much more comprehensive program. The point is, it's spending a little bit more money through the Medicaid program, but it's saving a ton of money on the back end because we're keeping them out of the hospital. And so by expanding Medicaid, there's an innovative program that's already got a proven track record that would be expanded to an additional patient population. The other thing, which it's innovative, I suppose, but we're in the middle of a pandemic, and I keep being asked down in Arkansas, you know, what can I do to increase my surge capacity? So we're a 25-bed critical access hospital, and I had to figure out ways of increasing my capacity, my bed capacity, up to 50, which we did. And one of the reasons we were able to do that is because we're in a Medicaid expanded state where I had the financial resources to be able to develop some surge capacity. But the point is, you expand Medicaid, then some of these hospitals that are being closed, and you know, my hospital in North Springfield, there's 110 beds that would still be available for surge capacity to the state of Missouri in the event of a pandemic that are not available because we failed to expand Medicaid and the hospital couldn't make it. So you don't have to think too much outside the box to see what advantages we may have in the future that, you know, you can't quite nail down, but would be there if you can strengthen healthcare providers and hospitals and clinics in this state by expanding Medicaid. Then we will be better able to innovate, but we will also be better able to meet the surge capacity required during pandemics. And, you know, we're going through one now, but nobody is naive enough to believe that we'll never have another pandemic.
Absolutely. I think you probably said it best. It is 1:30. I noticed that a couple of people have other commitments, and we understand. We want to thank everyone for joining this conversation too. There were so many key, important, salient points. I cannot emphasize enough that people need to just watch this again. And when we get the recorded link, we'll be sure to share it. It's through the Brown School. Thank you to the Brown School. Thank you to Open Classroom. We're gonna have a recording of this available. You really have to share this conversation. It went by really too quickly, but the points were just like hard hitting. For those who can stay on another minute, if every panelist could just in 30 seconds give me your concluding remark, the message you want to leave with people. And we'll start with Ryan and we'll move to Dr. Ross and then we'll go to Paul and then to Tim.
Ryan.
Oh, maybe we'll start with Dr. Ross and then we'll move over. Yes, if you got 30 seconds to hit it home for us.
So I always believe that ultimately the way to make this country healthy is to promote health equity. We want to ensure that every American has the ability to reach their full health potential. Every American, irrespective of whether rural or urban or ex-urban, black or white, low income, high income, everyone should reach their full health potential. Medicaid expansion is not a zero-sum game. It's just an opportunity for everyone to reach that full health potential. That's why we should be supporting Medicaid expansion across the board.
Paul or Tim?
Well, this is Paul, and I'll put it down, reduce it down to my level. I'm a proud Missourian. I'd like to be proud of Missouri for expanding Medicaid. I'm vaguely embarrassed. I'm sitting in 3 different states. And I've now in Arkansas and now even Oklahoma, and Missouri shouldn't be last. Come on, guys, let's get it passed.
I'll agree with what's said, and I've said this before in other venues, but Medicaid expansion is a no-brainer, and I think of it like an economist. Let me put it this way: and if somebody said to you, if I give you $1 and then you give me back, $9 or $19, what it was originally, would you take that bet? That's pretty much what this is. In fact, actually, based on our fiscal analysis, it says if I give you $0, I'll give you back, $2 billion. That's pretty much what it is, and that's pretty much the financial deal that you're being asked to do, and it's to help your low-income rural and urban neighbors that really need help in the whole state. And it's really a no-brainer. And it's dollars, as Paul mentioned earlier, we're paying our federal tax dollars. It's going to California, Illinois, and Michigan, and it just doesn't make a whole lot of sense. So.
And I will thank you for having me. And I will end with 2 things that I just posted in the comments a little bit ago. 2 websites for additional information. The official ballot campaign website is yesonto.org. And then the Missouri Foundation for Health, we have an educational website on Medicaid expansion, some facts and figures, and that is makessensemo.org.
Great website. Thanks, Paul, for being here.
Thank you so much. I think that's it, Cynthia. I just want to say thank you again. Cynthia, would you like to wrap it up for us?
I just want to thank all of our panelists and you, Latia, and our chat was jumping this afternoon. It was such a rich conversation. Thank you all so much. Enjoy the rest of your week.
Thank you. Bye, everybody.
Thank you.
Third part. Bye.